And when we explored the patient, we could identify the right superior parathyroid, which was normal in size, but there was no left inferior parathyroid. We looked into the central compartment, we looked into the carotid sheath, we looked retrotracheally, and I don't know what clicked or what made us decide. And I just removed the lower half of the thyroid gland, thinking that since most of the investigations are just pointing towards this place, let me just explore this. And I did a lower right lobe excision, and when I cut open that specimen, I was fortunate enough to find a small 7 into 7 millimeter parathyroid embedded within the thyroid tissue. So again, your instincts also work sometimes. And once you are sure that you have clearly identified other tissues that they are devoid of any parathyroid gland. So this was the specimen, and the parathyroid was embedded within that lower part of the thyroid. Then again, in another interesting case wherein there was failure of these localizing studies, recurrent hyperparathyroidism. A 55-year-old gentleman from Afghanistan was operated in 2011 for a left lower adenoma, biochemically proved primary hyperparathyroidism, and he presented with recurrent hypercalcemia tears. We evaluated the same endocrinologist and same surgeon who operated for the first time. They then referred this case to us. We re-evaluated, the calcium levels were high, pH was high, did a localizing study. PB scan showed was negative for any uptake in the neck or mediastinum. MRI neck and mediastinum again negative for any enlarged adenoma or tissue. PET scan negative for any area of significant uptake. So again it was a challenge, and we did plan an exploration with several possibilities in mind, like maybe the previous surgeon has not completely removed the parathyroid. Maybe there was a missed case of hyperplasia, maybe there were multiple adenomas which were enlarged, or maybe this was a parathyroid malignancy which has now recurred, or a rare entity called parathyroidomatosis. Sorry for this. And when we explored this patient, to our surprise, there were multiple small nodules studied over the thyroid, strap muscles, ipsilateral sternocleidomastoid. Ipsilateral, by ipsilateral I mean the area through which the primary surgeon did that endoscopic or minimally invasive parathyroidectomy for this case. And we picked up one of the nodules, sent it for frozen, that confirmed parathyroid tissue. So what we did, we removed whole of the thyroid lobe, ipsilateral thyroid lobe. We removed whole of the fibrofatty tissue in that compartment. We removed the strap muscles. We removed few layers of muscles of sternocleidomastoid and cored out the tissue of the entry point of ports where the previous surgeon has operated on. And we identified both normal parathyroids on the other side. So we left them in situ. And post-operative PTH, although we didn't have that aid of rapid PTH assays, but we did take a sample just to enhance our knowledge and ensure what we did. And that PTH levels came out to be undetectable post-operative, immediate post-operative samples. So again, how difficult parathyroidectomies can be, and especially people who are trying to approach these glands with laparoscopy and endoscopy, they should be well versed with first the technique, then identifying the gland, and third, to take care of the gentleness with which we handle the parathyroid, because any rupture in the capsule can lead to this kind of disaster. And in my training days, when our professor used to say, please handle with care, please handle with care, we were like, what is the big deal? Why don't we just take it out in, like a maybe nodule or lipoma? And probably after doing this case, I realized that why they were insisting on these things. So just a case of parathyroid cyst incidentally diagnosed during surgery. Basically we operated for a cyst in the neck, and since it was closely associated with one of the parathyroid glands. Then coming to the techniques of surgery which are recommended are a conventional technique, which means bilateral neck exploration, identifying all the glands and removing the enlarged glands. And a non-conventional approach, or the newer approaches, which means unilateral exploration or minimal invasive approach. Again, minimal invasive approach can be, it's basically can be, multiple terms can be used: targeted, focused, or minimal invasive parathyroidectomy. And another minimal invasive form is endoscopic parathyroidectomy. So these focused or targeted parathyroidectomy means we are trying to remove the only gland which we have identified by unequivocal investigation by nuclear imaging and radiological imaging, and the incision is given directly over the parathyroid gland. Whereas in endoscopic parathyroidectomy, the approach is same: we remove the only large parathyroid, but through an incision other than like maybe maxilla or periorbital. So that is the basic difference between the two approaches. And focused parathyroidectomy is nowadays the in thing, wherein we give a small incision. The advantages are minimal tissue dissection, better cosmesis, less pain, short hospital stay, and prerequisite, as I said, there is to be an unequivocal localization of the gland. Localization studies we have already discussed. MIDI scan is one of the most sensitive investigation and specific we have, sometimes aided by ultrasound and CT entirely. So this is how we do this minimal or focused parathyroidectomy with a very small incision directly guiding over the parathyroid gland. And intraoperative aids which we use to confirm our completion of our surgery is frozen section, rapid intraoperative QTH assays. A significant fall 10 minutes after surgery will suggest that you have removed all the enlarged or significant or pathological tissue. And gamma probe can be sometimes used to both guide the parathyroid towards parathyroid and ensure that there is no residual activity after whatever you have removed. So this is how endoscopic parathyroidectomy is done, wherein we don't give an incision in the neck but periareolar and 2 incisions in the bilateral axilla. So this is just to avoid a small incision in the neck. But unless you are very careful, you can land up in the disasters which I have shown. We also perform endoscopic parathyroidectomy, but for very selective cases, when patient demands, and especially for younger patients where cosmesis is of prime concern. I have a video, but because of shortage of time, I am not including it. And in the end, I would like to acknowledge my mentors, especially Dr. M.P. Arora, who taught me how to hold a knife, Dr. Gaurav Agarwal, who was quite instrumental in my endocrine surgery training, all my endocrinologist physicians for believing in me, and my pathologist, radiologist, nuclear medicine colleagues for helping me out in difficult situations. Thank you.
Give this excellent view of difficult cases to highlight how challenging parathyroid surgery can be, particularly in the setting of an ectopic parathyroid gland and their size being very small. You have mentioned the line about radio-guided parathyroid surgery. We have done a couple of cases recently at Fortis Hospital, and this is a very good technique to localize small parathyroid glands on the table itself. Gone are the days to do VTH levels immediately after the surgery. I think radio-guided parathyroid surgery gives a good localization procedure on the table itself, particularly when the glands are very small, and you can do a focused and targeted parathyroid surgery. Multiple adenomas are known to occur, and as Dr. Agrawal has said, we need to find a good parathyroid surgeon than to find a parathyroid itself, particularly in a setting when it's an ectopic gland and when there are multiple more than one adenomas. And he's done a really excellent job. I remember one of the cases that was referred by us, where a mediastinal small parathyroid, that lady, which is an oldish lady who had comorbid conditions, and is successfully removed there. Very nice.
Thank you.
Any questions?
Yeah, Dr. Vivek, so excellent talk. The symptom scenario, in India is particularly changing over the last few years because of the widespread vitamin D replacement by medications and other all. And when I saw the reports, what we used to see, PHPT about a decade back, is highly symptomatic, most of them becoming asymptomatic variety, particularly in Indian scenario. But the symptom scenario is changing over the years, number one. It was an eye-opener that despite a good surgery, some patients the TGF was persistently elevated and you could find the underlying cause. But there are some odd patients, some patients where we have seen surgery has been good, there was a good localization, there was no indication of any other tissue left or any other adenoma in the thyroid, but they continue to have high PGH over the years. And I could not find any cause why we see such kind of a patient.
Thank you, sir, for your nice question. But as I showed, most of these cases which were handled by the primary care physician or surgeon, they also thought that they have done a good job, and most of them were immediate post-op. One or two of them were immediately post-operatively they were cured by biochemical parameters. But unfortunately, whenever there is recurrence or persistence, the high PTH, persisting high PTH levels, the patient don't remain with you. So they'll end up with probably other people, and So I think first we need to check that what you call is adequate job was adequate or not. And unless we have a detailed profile of those patients, it is difficult to comment what happened in your patients. Most probably there will be one of these scenarios, either a missed adenoma, hyperplasia. We have seen even some of the people removing just partial parathyroid gland, reported as normal encapsulated gland, but actually it was a bilobe kind of parathyroid. Then there could be a case of hyperplasia wherein the other glands are very subtly enlarged and apparently they look like normal. So most of the scenarios you will see that if you review and retrospectively see the detailed profile of the patient and investigation, they will fit into these situations.
So you are right, suppose all the other glands they are hyperplastic or hyperplasia after a good surgery. So what do you do in these cases?
Pardon, sir?
Hyperplasia.
In hyperplasia, we will do a 3.5 gland parathyroidectomy. We will not go for this limited approach. This is a contraindication. This procedure is contraindicated in that situation. So, and that only we can ensure unless we have ensured by dual imaging, both radiological and nuclear imaging. Intraoperatively also, if we see that parathyroid is significantly enlarged with cross adenomatous kind of look. Once you are doing more and more parathyroid, you can even differentiate sometimes between a hyperplastic and a adenomatous looking gland. And then of course immediate fall of intraoperative PTH and radio frequency probes can help you adequacy of your job. And even if you are doing minimally or focused parathyroidectomy like Dr. Gaurav has taught us, you can just slightly dissect more and look into the ipsilateral normal gland and compare the size. So that again is sometimes helpful to find that okay, at least there is one more gland which is normal, and this case is unlikely to be that of hyperplasia. So
thank you very much for your excellent talk.
I would like to make certain comments on it. Number one, the question further which the doctor has mentioned here, that the scenario is changing now, as in India, all over the world. They say that the symptomatology is different in US and Western Europe than in India.
yes.
Number one. Number two, which I wanted to make a comment about, which was asked about the hyperplasia. If you are not able to locate, this localization is the most important thing in a parathyroid adenoma, in primary hyperparathyroid adenoma. If you are not able to localize, you should think of hyperplasia with hypercalcemia. This you must know. And then you have to do it. There is no two things about it. If it's an adenoma, there is hyperparathyroidism, you remove only the adenoma. If there is no localization, it means it's hyperplasia. And the other comment which I wanted to make, minimal access surgery. The minimal access surgery concept of this laparoscopic or endoscopic, as we are saying. Now, there are so many variations. Things are coming now to minimal access is the localization of the adenoma and making the smallest incision possible. Whether you will make it 2.5 centimeter or 5 centimeter. So these are the concepts which one has to know about minimal. One should not go for pride for endoscopic surgery and then localizing the gland. Thank you.
So thank you for your comments. Your points are well taken, but we are practically doing all variations of surgeries, and it is more important to choose your case. I mean, you cannot operate or you use a technique for just because you know that technique. I mean, you have to really select your cases and
it has to be tailor-made.
Yeah.
Do you make any role of PET scan, PET MRI?
Sir, PET MRI and PET scan actually have very limited role as of now, as we showed in one or two cases where we could not localize in pre-operative setting. We occasionally do PET scans, but the sensitivity of BB scan and ultrasound and plain MRI is almost it's that good that PET scan doesn't give additional value. So we have yet to see a case where PET has actually helped us.
I think as of today, PET scan doesn't have much role in the diagnostic evaluation. Better is to combine the nuclear medicine with MRI or an ultrasound. The two correlated together can help in proper localization pre-operative. And per-operatively radio-guided localization is an important thing for parathyroid.
You said that is 1 milligram above normal level of this, an indication of surgery. What is your normal level? Is it different in different settings?
No,
1 milligram per ml.
1 milligram above
1 milligram per ml.
per ml.
per ml above the normal range of that lab. So normally we take it as 8.5 to 10.5 milligram per deciliter. So patient is presenting with 11.5, yes, that is a definite indication for surgery.
Yes, please.
Dr. Agarwal, very nice presentation, a good job done, 92 cases in 5 years. Very good. I was actually interested in seeing how many normocalcemic hyperparathyroid patients were in this series of 90s. Were you accessible to vitamin D level?
I had given you dissection of that figure, but none of them was normocalcemic hyperparathyroidism. We did have asymptomatic hyperparathyroidism for about 4 cases, but all of them were biochemically screened patients with high calcium levels. They were asymptomatic, but I have yet to see a case of normocalcemic hyperparathyroidism.
Actually, what we see in AIMS, most of times have vitamin D levels very low. And I don't know whether that is a selection or referral bias. Significant number of patients do have calcium in the normal range and they come for other reasons. This is a quite good number, so vitamin D levels are low, possibly because of that. So I thought 92 you must be having.
Yeah. So if you look at the definition, if there is associated vitamin D deficiency, then this is a secondary cause of that high pH. And when we correct that vitamin D deficiency, either the calcium levels will, most of the situations you will find that calcium level starts rising well above the normal range if they are cases of primary hyperparathyroidism. Most of them. So,
yeah, that is another enigma like
that doesn't fit into
tertiary
the definition.
and what is the idiopathogenesis?
So that doesn't fit into the definition of normocalcemic
Right.
hyperparathyroidism if
If you
there is
find-
underlying vitamin D deficiency.
If you find a vitamin D deficiency with hypo or normal calcium level, first you try to correct that vitamin D deficiency.
And if still
If
that,
if after that also you find it's a primary hyperparathyroidism, calcium levels will shoot up usually, and then you may really investigate for primary hyperparathyroidism. Thank you. I think last question, please.
Actually, this is a point from my side. Actually, I was part with Vivek in most of these cases. Maybe out of 90 to 72 must have been worked by me and them together. So practically, we did vitamin D in very few cases. Maybe economical constraint or whatever you can say. But one of cases, still remember, the girl got vitamin D, her calcium was about 9 point something, and after vitamin D, which was given by somebody, it went to 17. So that girl we diagnosed as parathyroidism and updated. So vitamin D we could not get in most of the cases.
And that was a very young girl, I suppose.
Yeah, it was 15 or 16-year-old girl. Just calcium was 9 and she got one arachidonic injection somewhere. And calcium was 17. So it turned out to be a
Thank you, Dr. Agarwal. I think one a wonderful presentation and we became wiser with your presentation. Thank you.
Now I request Dr. Parul Sehgal to please hand over token of appreciation to our speaker, Dr. Vivek Agarwal. Now I request Dr. Parul Sehgal to please hand over token of appreciation to our chairpersons, Dr. T.K. Kusu and Dr. T.L. Bhatt. We will be making some changes in program. First, we will not have any formal tea break as we are already running short of time. And Dr. Vangu has to leave early, so we will be making the panel discussion early. So the next program will be the panel discussion, and the topic will be subclinical hypothyroidism, whom to treat and whom not to treat. So nowadays the most of the one of the common endocrinology referral is nowadays is subclinical hypothyroidism. So the panelist will be Dr. S.K. Vangu. Dr. S.K. Vangu is Senior Consultant and Head of Endocrinology at Apollo Center for Obesity, Diabetes and Endocrinology. And he is a professional member of various endocrine societies like American Diabetes Association, ESD, and International Diabetes Federation. And he has published lots of international and national publications. So now I request Dr. Vangu to please come over the dais. The next panelist will be Dr. Rajesh Khadgawar. I request Dr. Rajesh Khadgawar to please come over the dais. Dr. Rajesh Khadgawar is Associate Professor of Endocrinology and in charge of Pediatric and Adolescent Endocrine Clinic at All India Institute of Medical Sciences, New Delhi. He has more than 50 national and international publications from various aspects of endocrinology, and his main areas of interest are growth disorders, childhood obesity, and pediatric endocrinology. The next panelist should be Dr. Ajay Ajmani. Dr. Ajmani has already been introduced. I request her to please come over to the dais. And the next panelist will be Dr. Tarun Sekhri. I request her to please come over the dais. Dr. Tarun Sekhri is currently the head of the thyroid department in New Delhi. So now I hand over the session to the Dr. S.K. Vangu. So please take over the.
Good afternoon, everybody. Sorry to just disturb your program because I had to go for another meeting in another hospital. I think I must congratulate Vivek and his team basically to organize this thyroid and parathyroid update, and we have learned a lot by the various lectures we heard this morning. And one of the biggest challenges to the endocrinologist and treating physician is to manage the subclinical hypothyroid state. And there have been a lot of controversies, guidelines, when, how, and in what way to treat the subclinical hypothyroid, in what group of the patients, and what are the fallacies, and what we are going to achieve by when we are treating the subclinical hypothyroid. What is the real clinical benefit of treating the subclinical hypothyroid state? So we have a panel of experts, and I must say they are who is who in the field of thyroidology. Dr. Khadgawar, Dr. Tarun Sekhri, Dr. Ajay Ajmani, and in particular Tarun has a large experience of dealing with the thyroid patients, and we could learn a lot from him. Now coming to the basics, that subclinical hypothyroid state, how to define, and what are the fallacies, whether we have a standardized PSHS assays available in our country, and what normally we come across various values, whether we are over-treating our patients or not, because various laboratories will give the various different kind of values of TSS, and the treating physicians just see the report and try to treat the patient. So before we discuss the various groups of the patient, let's see what really define how we can come down to the selecting patient whether he is really having subclinical hypothyroid by definition and what is the clinical benefit of treating subclinical hypothyroid patient. Over to Tarun because he has a larger experience and he can tell us better when, how we can diagnose the definition of subclinical hypothyroid.
Thank you, Dr. Wagner. At the outset, I'd like to thank the organizers for inviting me here and especially Vivek, who in fact not only invited me, he shared this update almost 2 months back. And he said, you block your 21st. So I'm grateful to him for, giving me adequate time also to, plan my schedule accordingly. So, coming straight to the question, how do you define subclinical hypothyroidism? Very simply put, subclinical hypothyroidism is when free T3 and free T4 are normal and TSH is on the higher side. So this is a very simple definition, high TSH, normal T3, T4. But now, lately, in last, I would say in recent few years, the controversy has emerged is how do you define the normal TSH? Till I would say 5 years back, it used to be 4.2 to 5, so around that much the TSH or more used to be defined as that. But now there is no consensus, but different groups, some groups have even said that 2.5 should be the cutoff. American Endocrine Association says 3 as a cutoff. But very recently, NHAENS3, they say that in it's age dependent TSH. So like 20 to 29 years, they say anything around 3.6 should be taken as a normal. Whereas in older age groups, especially in 60 and around, it's 4 point something. 61 to 69 is about 4.7 or so. 71 to 79 is about 6 point something, and anything above 80 would be 7.8. So at times, again, I don't want to confuse you, but there is a lot of confusion regarding cutoff of normal TSH. But still, generally, anything more than 4.25 is definitely high TSH. And now coming back to, as he said, whether there are clinical benefits or not. So it's again a huge topic, but I would just want to highlight that world over there is consensus that TSH of 10 or more with normal T3, T4, there is no confusion, in giving treatment. There are evidences, enough evidences where they show that people treated with more than 10 TSH would benefit. But again, that group between 5 and 10 of TSH, it's not very simple. I mean, it's again, it may vary from case to case. When to treat, how to.
Thank you, Tarun. And Rajesh, would you really tell me what is your perception when you just tell me these are clinical hypothyroid state and whether this is, you see the age of the patient, whether that could be cut off or not, or you just tell a simple cut off TSH 4.5 to 10 or something?
As Dr. Tarun has defined, like subclinical hypothyroidism, there is mild elevation of TSH. It may represent one of the two states. It may be the early stage of hypothyroidism, which is still evolving. So it may repeat thyroid function after some time. TSH may go up, or it may represent just variability in measurement of TSH. So if we repeat TSH after some time, it may come to normal, or it may remain mildly elevated. But yes, if we talk about TSH, that age dependent cutoff has been given. But as of now, what we are doing, what we are following is, if TSH is more than the upper limit of normal of that lab, is considered as subclinical hypothyroidism. Suppose if we are using an assay
which is immunofluorescent assay, which is very sensitive, we can take a cutoff of more than 4.2, or if we are using less than that, we can take a cutoff 4.5. Although there are assays, as these cutoffs have been given on the age base, but more of now we are using higher than the upper limit of normal. Sometimes it may depend on what type of assay you are using. If you are using a lab which gives normal range as 5.5, sometimes lab gives 5.2. So anything more than that may be considered as a subclinical hypothyroidism if 3T4 or total T4 is normal.
In continuation of your this answer, I would like the audience to know how you are going to follow up this patient, how frequently you are going to repeat the test, depending upon the diagnosis of clinical with the patient with a positive or negative thyroid peroxidase antibodies. What is the current guidance is?
So now we have one patient for this thyroid function test was asked for some reason, whether that was related to patient's symptoms or not, but now we get a report TSH of 7.5, T4 or T4 is well within normal limit. None of his symptoms at this stage cannot be explained on the basis of subclinical hypothyroidism. So if we are looking any explanation for symptoms of this patient, then we are not sure this is not because of high TSH, which is mildly elevated. All functions, all symptoms are related to the T4, so these symptoms cannot be explained. Now question is, how do we approach? There are high risk group. If patient falls in that group, then we need to treat this patient proactively, and these groups are, I think we'll discuss later on, like pregnancy, infertility, if there is a basic thyroid disease in form of nodular thyroid. In these cases, we may aim to treat these patients early, otherwise we wait till TSH crosses 10. We may repeat the thyroid function test after 3 months or 6 months. If TSH rises progressively, it crosses 10, we can think of starting treatment, but anything less than 10 in a patient who is not belonging to the group of infertility or pregnancy or goiter, in these cases we would like to follow up these patients with measurement of TSH subsequently over after 3 months or maybe after 6 months.
So the guidelines say we should follow the patient after 3 months or 6 months, because we have to tell what is the advocate thinking that whether we should follow after 3 months or 6 months. Because the 6 months, 3 months are no long gap, because after 3 months the patient goes more than 12 and we wait for 6 months. But that has to be have some clinical bearing or not. So we should have a clear-cut guideline that we should follow the patient after 3 months or 6 months.
So that depends on TSH level. If you are seeing mild elevation which is less than the 2 times of the TSH upper limit of normal, you can recheck after 6 months. If the elevation is more than 2 times, like if your upper limit is 4.2, it's more than 8.4, but it's still less than that, you can repeat after, you can